Great, thanks. So just one case to stream today. This is a dog that has presented with a soft tissue sarcoma on its commissure of the caudal commissure of its lips. You can't see that in view here. We also have this rather large lipoma. So we're going to remove that first. Whenever you're dealing with multiple masses, you want to go from most benign to most malignant. So in this case, we've got a benign lipoma, and then we'll move on to the malignant soft tissue sarcoma. This dog has a number of lipomas, so we're only removing the one kind of problematic one. And I'm going to preserve some of the skin over this just so we can close primarily with not too many difficulties and close that dead space. And this other one's just there, so just going to remove that just by happenstance. We may have to trim off some other skin afterwards, depending if it's still excessive. It's almost necrotic. Yep. I know, Craig. Okay. I don't usually worry about those ones too much because they're just about to come out. The vessels in those kind of in masses, it's called neovascularization, and they're usually very thin-walled and difficult to control. So usually just kind of plough forward and let that be. I kind of feel like a ligature might be a good option too, though. Can you hit the button for a ligature, please? Can I have a ligature, please?
Yeah. Can we also get more gauze, please?
Sure.
Please.
That's okay.
Oh, really? We're not past that.
I use a bunch for like the prep.
Makes sense. And do you mind popping in while you're here as well before you leave? Yeah, of course. Do you guys want a suture or anything while I'm in here?
Sure, it's 3/0 monocryl and 3/0 nylon, please. No, I'm just not sure this is lipoma.
Once you say that, just like this glandular look, it doesn't have smooth capsule.
Yeah, it doesn't really look like a lipoma. It's more of a myxosarcoma feel to it. Just swell in there. You can just hold that there. Thanks. Hold that there. Can you hit the button, please? That ligature's dead. It's not cutting. Yeah, if you hold it towards you. See kind of the difference between that and that.
Yeah.
You can sometimes get necrotic lipomas which have more of that feel, but this is more smelling like a myxosarcoma or that kind of thing. It's a bit more towards you again. So certainly not what I wanted to see.
Should probably recommend radiation therapy for these guys then? The client?
Radiation therapy is not worth a pinch of salt. So if you look at the literature, nothing improves the local tumour control in dogs with soft tissue sarcomas. So radiation therapy, local reoccurrence rates with surgery alone in the order of 11 to around 28%. with with surgery and radiation therapy, it's between 18 and up to 60%.
I thought it dropped as low as 5%.
That's mast cell tumours.
Okay.
So no. And with intralesional cisplatin beads, it's 25 or 28%. With ECT, it's 26%. So nothing changes the local recurrence rate. The only thing that's so that recommendation is largely based on human medicine, where they tend to have more aggressive. These kind of things are considered benign, which is more unusual for in people. And the most recent study showed that radiation may be effective for like grade 3 versus grade 1 and 2, where it has no effect, which is what has also been shown in people. And then the other consideration is that radiation, like all those studies were done many years ago, except for the most recent one. And so with intensity modulated radiation therapy, the outcomes may be better. So that needs to be looked at more. This owner in particular won't do it. He's fairly financially strapped, but also the dog's 14, and this has been here for years. So he was like, no, if it comes back, it comes back, and we'll live with it. But the recommendation for radiation is not evidence-based, put it that way. There's a big debate about this on the FSO listserv recently. That looks more lipoma-ish. This will run there. Okay, so that's that out. Now we've got this defect here. Just let's see how easy this will close. Okay, so why don't we try that? Corey?
Julie, can I ask you some questions?
Mm-hmm.
For Lulu, the owner is going to come pick her up in 30 minutes.
Okay.
In terms of her incision, does she need to wear an e-collar? Do we need to do hot and cold?
No, nothing like that.
For her meds, you said trazodone and buprenorphine as previously prescribed, but we did Medicam and gabapentin.
Okay,
Like before. So do you want,
that's fine.
we'll just do Medicam and gabapentin? Or
I thought she was already on GABA and Bupe from the Emerge.
it wasn't prescribed, it's not in her prescribed meds.
Oh, okay. Then yeah, just is she on GABA?
She got GABA this morning. I don't know what she is like on, like long term.
So just do GABA for 14 days and Medicam for say 10 days.
Okay. And then in terms of the estimate, it was quoted like a full explant sort of deal.
Yeah.
I imagine we're just doing like sedation, level 1 sterilization, like it's just a couple $100.
Sure.
Okay.
Yeah. Do you see one?
No.
Okay. So do you want to just do subcute and skin on that? I'll move on to that. Grab that one there. I'll Move that over there, that over there. Grab another pair of gloves.
Yep. Fine.
Size 7.
Just regular ones?
What's that?
Just regular gloves?
Yeah.
Okay.
Let's get you to take those off first.
Yep. Just when we go here, you'll be grabbing
Yep.
the sleeve too.
No, the sleeve's over my hand. Thanks. Thank you. Or you can use, use those. Yeah, use those ones. So Matteo's just going to close that wound. We've removed some skin just to reduce our dead space afterwards, to reduce the risk of seroma formation. This may not be a lipoma, so I'm going to send this off to the lab for analysis. It had a feel of a kind of a myxosarcoma and the appearance of a soft tissue sarcoma rather than a lipoma. This dog is 14 years old, so the owner is unlikely to do anything more than this anyway. And it's been there a long time, so it's likely low grade. So now we're just going to move on to our next site. Can you call one of the assistants? Can you just widen out the view for us?
Sorry?
Widen out the view on the... Okay, that's good. That's great. So you get both Matteo closing up the other site, and this is the soft tissue sarcoma in the lip region. This is the caudal commissure of the lips. Head is towards the... Where's my finger? That way. So this is subcutaneous. I can freely move the skin over the top of it. There's also a lot of tissue around, so I'm just going to make an incision around the base of it and then widen it out from there. I've changed gloves because I'm dealing with a different tumour type and using different instruments. So we're not cross-contaminating. So I'm just going to incise around the base of the soft tissue sarcoma here. Coming across the caudal commissure of the lips here. Actually, what I might do is just try and get closer in on the soft tissue sarcoma and kind of leave you guys to imagine what Matteo's doing. Let's use some light there, Matteo. What's that?
So Matteo's going to imagine what Matteo's doing.
You good there, Matteo?
Yeah, good, thank you.
And can you call the Jessie or someone? Sorry, I've decided that Matteo's had enough of the limelight. Can you focus on this one?
Yeah.
closer. A bit closer. That's good. Thanks. Okay. So again, this is our soft tissue sarcoma. Head is towards this end, back is towards that end, and we've just done an incision around the base of it, and just kind of going through full thickness now with the cautery. Swab there. Swab.
I did touch that too.
Okay. Okay, so we've come through the skin now. It's going to come wider on the soft tissue margins here, subcutaneous margins. We'll likely have to go through full thickness through the lip at some stage to get our deep margins. That shouldn't be too much of an issue. I wonder if we're down to our...
You mind passing the iPhone, please?
So we're kind of down to our deep margins now. This is all free lip here, so I'm just going to cut through the lip. Here's our deep margins, this is our full lip resection. Oops. Hello.
For Lulu, she has an adverse reaction to Medicam.
Oh, that's right.
Yeah.
So just do buprenorphine for 5 days instead.
5 days?
Yeah.
Okay. And then does she have any exercise restrictions?
No.
Okay.
Okay, that's tumor 2 out. Can you call someone to put a mouth gag in? Hey, can you see if you can get a mouth gag in? We've got an epiglottal mass.
Do you want to put it in, or do you want me to put it in?
If you can put it in. No, I can put it in. That's okay. As in,
Do you want me to give you another set of gloves after?
no, I won't touch the part that you touched.
Sorry, Julius.
No, it's okay. Oh, it doesn't. Oh, there we go. So this dog also has a little epiglottal mass here, and while everything's might be a tonsillar mass actually. So while the lip is more exposed, I thought that might be easier to get. It'll be fine. It'll be fine. Oops. So, can you see that? Not really. Can you call someone in again? So we can zoom in on this mass here. I wonder if we can get a better view somehow. Oops. Okay, that might have to do. Thanks. So this is a tonsillar mass here. It doesn't look too concerning. So I'm just going to use the ligature here at the base of it to remove it. Whoops. And there's a tonsillectomy. There's no bleeding, so anesthesia is going to be happy with me. And now we can go back to closing. If you can call them back in again. Sorry, now I've done the tonsillectomy. Can we reposition here again? And can I grab some 2O PDS? That's great. I've come closer actually. That's good there. Can I grab some 2O PDS? 3O monocryl and 3O nylon, thanks. Thanks, that's okay. So whenever you're reconstructing lips, it's important to align the lip margin first. So that's what I'm going to do here. It's kind of like, not as important, but kind of like eyelids. And just because of the tension, I'm going to close this in an interrupted pattern just with cruciates. Okay, so that's the mucosal layer closed. Yeah.
Can I go over a post-op with you?
Mm-hmm.
Did you want meloxicam injection for this one?
Yep.
Okay. And then we were going to do back 1.1 mg per kg Q4 until 3 hours prior to discharge. Continue the ketamine CRI, and then buprenorphine 0.02 mg per kg 1 hour prior to discharge.
Okay.
And for the samples, we are doing a mass on the chest and then the mass on the lip. Just those two, or the one from the.
We'll do the one. We'll do the one from the tonsil as well.
Okay.
It's a tonsillar mass, just so you know.
And did you need anything prior to recovery for him?
No.
You did like the buccal side, you just did a 1 layer, but 2 layer on the outside here?
No, it's going to be 4 layer. So mucosal, submucosal, subcute skin. I can finish. I can finish this off, Matteo, rather than getting you to change gloves and everything else. Thanks.
You said one you get gloves?
No,
Oh,
I can close this rather than you having to
I see.
get changed and everything. As it's our last case, it's nowhere for me to rush off to.
Yeah.
You do the pin removal?
Yeah. That was just a 5mm incision and pull the pin in.
How's the cat doing?
It's doing well. It feels stable, so it's actually quite surprised that it didn't migrate, because we're 8 weeks post-op now, so those pins usually migrate far earlier, so I was happy that we got out to 8 weeks.
I think that might have been the first surgery we did together.
Was it?
Maybe, I believe so.
Ironic that's an orthopedic.
It was a deranged cycle.
Yeah, so lateral meniscus pin stabilized. The cycle on 30 degrees. That's cool.
So they came together pretty nicely.
Yeah. Not too bad.
Now if you can just pop that scalpel blade off. Just grab the... Okay, yeah. Thanks. So as you can see here, the lips nicely aligned. Let's come back in a bit more there. Oops. So do either of you have any questions about soft tissue sarcomas, lip surgery, anything? Fill the space, fill the silence.
I was wondering how, like we switch equipment and everything and move between tumors, but
What's that?
like we switch equipment and everything and we move between different tumor types, but like the ligature, we keep the ligature and it's got the like hot contact plates, but it's still got that blade in it.
Yep,
Is
it's
it
a
really- it's more of a,
it's a good point. Theoretically, we should probably be changing that as well. I don't know the value. No one knows the value of changing gloves and instruments.
oh, okay.
Like theoretically, it's a good thing to do. And you're correct. I should have probably changed cautery pens and ligature blades and that as well.
That was my question.
Yeah,
Is it just kind of good practice or is it a...
it's good practice. Yeah.
do we have to- Just tension there, hold on, I think otherwise. There we go.
The ventral sternum is always a really challenging place because it hasn't got that much mobility in this adjacent skin, and there's the only flap that works in that region, and sometimes it doesn't reach, is the axillary flank fold. So it's a challenging place to go and make wide hole or big holes.
Did you do the cranial epigastric?
Never done that one, so I don't know how successful that is. Have you ever used it or seen it used?
No, I haven't seen it. I was just looking up ways to get a defect around this region. What would you use?
I've used the thoracodorsal, and that was a big failure. And the axillary flank fold tends to work well, but often you need to do bilateral to get
Okay.
both sides reconstructed because it doesn't fit all the way across.
I think from the small study for the cranial epigastric axial pattern flap, I think it was a study of 6 dogs. I think it had a complete failure rate of 50%. So
Yeah. Okie dokie, all done there. That's done. So all sharps are off. Okay. Don't think we need to ink any of those. Just fill that out. So all 3 samples are on the table. I'm not going to ink them. So we're all done. And all the sharps are off. Is that off?
I cut it off.
Great, thanks. Let's quickly measure that tonsil mass.
Something really satisfying about that tonsil mass. So well marginated, such a little.
Can you stop the stream, please? So we're just signing off, and we'll see you next week.